Welcome to our deep dive on the heart and circulation. Whether you're a nursing student,
Yeah,
brushing up on your cardiac assessment skills,
absolutely.
or a seasoned faculty member looking for some fresh insights, we've got you covered.
We do.
So let's imagine you're about to examine a patient
Okay.
with a potential heart condition.
Right.
Where do you even begin?
Well, before we even touch the patient,
Okay.
it's crucial to have a clear mental picture of
Yeah.
where the heart actually sits in the chest.
Okay, so we're talking anatomy 101 here. Most people probably think the
Yeah.
heart is right in the center of the chest,
Uh-huh.
but it's a bit more complicated than that, isn't
And
it?
it is. The heart is nestled within a space called the mediastinum. Think of it as a central compartment in your chest
Okay.
that also houses a lot of other important structures,
Okay.
like the great vessels, the esophagus,
Mm-hmm.
trachea, and even some key lymph nodes.
Wow, so it's a pretty crowded neighborhood in there.
It is.
But let's zoom in on the heart itself.
Okay.
Where exactly is it within this mediastinum?
The heart is slightly shifted to the left,
Okay.
and the right ventricle is actually the most forward-facing chamber.
So the right ventricle is the one that's most closest to...
Yeah, it's anterior.
Okay.
This is one of those things that can trip people up,
Right.
especially when interpreting ECGs.
That's a great point. Knowing that the right ventricle is anterior can help explain why certain ECG leads might show more prominent R waves in conditions like right ventricular hypertrophy.
Exactly. And speaking of ECGs, understanding surface landmarks is crucial for accurate electrode placement.
Okay.
The base of the heart, where those important valves are located, is actually level with the sternal angle.
Uh-huh.
That's that bony ridge you can feel where the top part of your sternum meets the body.
So the base isn't the anatomical top of the heart,
Right.
like you might intuitively think.
And then the apex,
Okay.
the pointy bottom tip formed by the left ventricle, points down and to the left.
Okay.
This is where we find the point of maximum impulse, or PMI.
The PMI, that's that thump you feel when you press your fingers just below the left nipple, right?
Precisely. It's usually found in the fifth intercostal space, a bit to the left of the center of your chest.
Okay.
But remember, things like body type and position can make it tricky to locate in some patients.
Now, why is the PMI so important? Is it just about finding the heartbeat?
It's much more than that.
Okay.
The PMI actually reveals the left border of the heart,
Oh,
which can tell us a lot about what's going on inside.
this is where things get really interesting clinically.
Yeah,
A displaced or enlarged PMI
right.
could be a sign of something serious, right?
Absolutely. It could indicate a range of conditions.
Like what?
For example, in someone with long-standing high blood pressure,
Okay.
you might find their PMI is shifted down and to the left because their left ventricle has become enlarged from working so hard.
What about lung problems? Could they affect the PMI too?
Definitely. In patients with COPD, for example, you might find the most prominent impulse down near the bottom of the sternum because the right ventricle has enlarged due to the increased pressure in the pulmonary circulation.
So the PMI is like a window into the heart's workload and structure.
Exactly. Even heart attacks or heart failure can cause shifts in the PMI. That's why careful palpation is so crucial during every cardiac exam.
Okay, now that we've got a sense of where the heart sits and how its position can reflect underlying conditions, let's dive into the actual mechanics of how blood flows through this incredible organ. Are you ready to trace the pathway?
Let's follow that flow.
It all starts with deoxygenated blood returning from the body, entering the right atrium.
Okay.
Then it flows through the tricuspid valve into the right ventricle.
From there, it's pumped through the pulmonary valve into the pulmonary artery and off to the lungs to pick up some fresh oxygen.
Then that oxygen-rich blood returns to the heart
Uh-huh.
via the pulmonary veins,
Yep.
entering the left atrium.
Right.
It passes through the mitral valve into the left ventricle, the heart's powerhouse.
And finally, it's forcefully ejected through the aortic valve into the aorta, the body's main highway, to deliver oxygen to every single cell.
It's amazing how those two circuits, the pulmonary and systemic, work together seamlessly.
Yeah.
And we can't forget those valves, ensuring everything flows the right direction.
We have two main types of valves.
Okay.
The atrioventricular valves,
Okay.
which include the tricuspid and mitral, separate the atria from the ventricles. Then we have the semilunar valves,
Right.
the pulmonary and aortic, which control the flow out of the ventricles.
So it's all about pressure gradients, right?
Right.
Blood always flows from areas of high pressure to areas of low pressure. And this brings us to the heart's rhythmic contraction and relaxation, systole and diastole.
Think of systole as the powerful contraction of the ventricles, propelling blood out to the lungs and the body. Diastole is the relaxation phase when the ventricles refill with blood.
And those valves play a crucial role in orchestrating this dance. During systole, the aortic and pulmonary valves open to allow blood to flow out, while the mitral and tricuspid valves close tightly to prevent backflow.
Then, as the ventricles relax during diastole, those roles reverse. The aortic and pulmonary valves close to prevent backflow, and the mitral and tricuspid valves open to allow the ventricles to fill again.
What's fascinating is that these valve actions actually create the sounds we hear when we listen to the heart with a stethoscope.
That's right. Those sounds are like clues telling us about the heart's function.
Well, I'm ready to decode those clues.
Okay.
Let's dive into the symphony of heart sounds.
Let's do it. Those heart sounds are like a language, and becoming fluent in that language is essential for any nurse.
Okay, I'm ready to become fluent.
Okay.
Let's go beyond the basic loop dub.
Okay.
What exactly are we hearing when we listen to the heart?
Those sounds, S1 and S2, are caused by the vibrations created as the valves close, blood flows through the heart, and the heart itself interacts with surrounding structures.
Okay, so let's break down a single heartbeat.
Okay.
I'm picturing myself with my stethoscope, listening carefully.
Great. So we start in diastole.
Okay.
The left atrium is filling with blood from the lungs, and the pressure gradually builds. This pressure pushes the mitral valve open, allowing blood to flow into the left ventricle.
Okay.
Then, just before systole, the left atrium gives that extra little squeeze to push the last bit of blood into the ventricle.
Okay, so the atrium kind of helps out.
Exactly. That atrial contraction, sometimes called the atrial kick, is especially important in patients with certain heart conditions.
I could see how that extra push would be vital if the heart isn't pumping as efficiently as it should.
Right. And then systole begins.
Okay.
The left ventricle contracts powerfully, and that mitral valve snaps shut to prevent backflow.
Okay.
That closure is what creates the first heart sound, S1.
So that's the lube we hear.
Precisely. And as the left ventricle continues to contract, the pressure builds until it forces the aortic valve open.
Okay.
Blood rushes out into the aorta and the rest of the body. Then the ventricle relaxes, the pressure drops, and we hear that aortic valve closing, that's S2, the dub.
Right.
And remember, while we've been focusing on the left side of the heart, a similar dance is happening on the right side simultaneously.
Right, with the right atrium, tricuspid valve, right ventricle, pulmonary valve, and pulmonary artery. It's like a perfectly synchronized mirror image.
It is, and this is where we get into the fascinating world of split heart sounds.
Split heart sounds, what does that mean? Is it like an echo?
In a way, yes. It's most noticeable with the second heart sound, S2.
Okay.
Remember, S2 is actually made up of two components, A2 from the aortic valve closing and P2 from the pulmonic valve closing.
So sometimes we hear two distinct sounds instead of one clear dub?
That's right. And here's the interesting part. A split S2 during inspiration is perfectly normal.
Wait, really? I would have thought that was abnormal.
It's all about the changes in pressure and blood flow that happen when we breathe.
Okay.
During inspiration, the pressure in the chest decreases slightly, which increases the amount of blood returning to the right side of the heart.
So it takes a tiny bit longer for the right ventricle to eject all that extra blood.
Right.
And that delays the closing of the pulmonic valve.
Exactly. That slight delay creates that audible separation of A2 and P2, the split S2 sound.
So it's like a little whisper telling us that the heart and lungs are working together in harmony.
Exactly. It's a subtle but important clue that everything is functioning as it should.
Okay, so splitting of S2 on inspiration, good. But what if we hear a split S2 during expiration?
That's when we start to think about potential problems, like a delay in electrical conduction to the right ventricle, or a problem with the pulmonic valve itself.
Now, what about S1? Can that split too?
It can, but it's less common and usually less noticeable. The sound of the mitral valve closing is usually louder and masks the sound of the tricuspid valve closing. If we do hear a split S1, it's often best heard at the lower left sternal border.
Okay, so split S2 on inspiration, normal. Split S1 or split S2 on expiration?
Yeah.
Time to investigate further.
You got it. Now, are you ready for some real detective work?
Bring in the mysteries. I'm feeling like a cardiac Sherlock Holmes.
Excellent, because heart murmurs are the true detective stories of cardiology. They can tell us so much about what's going on inside the heart.
Heart murmurs?
Yeah.
Aren't those caused by turbulent blood flow?
Exactly. Imagine a river flowing smoothly over a smooth bed. Now, throw some rocks in there, and the water starts to swirl and churn. That's essentially what's happening with a murmur. There's some disruption to the smooth flow of blood through the heart, and that creates those extra sounds.
So are all murmurs bad news?
Not necessarily. Some are what we call innocent murmurs, especially in children and young adults.
Okay.
These are often soft, don't have any other concerning features, and don't indicate any underlying problems.
Okay, so how do we distinguish between those harmless murmurs and the ones that signal a problem?
That's where the real detective work comes in.
Okay.
We have to pay close attention to the location, timing, and qualities of the murmur.
So each murmur has its own fingerprint.
Precisely. Narrowed valves, called stenotic valves, and leaky valves, called regurgitant valves, both create distinct murmur patterns. And knowing those patterns is like having a secret decoder ring for the heart.
I don't understand why cardiology could be so fascinating.
Yeah,
It's like solving a puzzle with every patient.
it really is. And we're just getting started. There are so many other clues we can gather from the physical exam, like the jugular venous pressure or JVP.
Ah, yes. The JVP, I remember struggling to learn that one in school. It involves looking at those veins in the neck, right?
That's right. The JVP reflects the pressure in the right atrium, which gives us a window into the right side of the heart.
Okay, let's break this down a bit.
Okay.
Which vein is the best indicator?
Ideally, we look at the internal jugular vein, but it can be tricky to see directly.
So we don't just stare intently at the patient's neck and hope for the best.
Not quite.
Okay.
We're looking for the highest point of pulsation in the neck, which is often subtle and transmitted to the skin surface.
Okay.
Good lighting and a keen eye are essential.
And then we measure that vertical distance above the sternal angle, right?
Correct. But remember to add about 5 centimeters to account for the anatomical distance between the sternal angle and the right atrium.
Why is the JVP so important clinically? What can it tell us?
An elevated JVP can be a sign of a variety of conditions.
Like what?
Heart failure is a classic example.
Okay.
If the heart isn't pumping efficiently, blood can back up in the venous system, and that increased pressure is reflected in the JVP.
So a high JVP can be a red flag for heart problems. What else can it tell us?
It can also be a clue to other conditions that cause fluid buildup,
Okay.
like constrictive pericarditis or volume overload from too much intravenous fluid.
So it's another piece of the puzzle, helping us differentiate between different possible diagnoses?
Absolutely. Now, there's one more pulse we need to master, the carotid pulse.
The carotid pulse.
Uh-huh.
That's the one in the neck, right alongside the carotid artery.
Exactly. It's a direct line to the aorta and gives us valuable information about how well the heart is pumping blood to the brain.
Okay, but before we jump into feeling the carotid pulse, there's something important we need to do first, right?
You're right. Before we palpate the carotid artery, we always listen carefully with our stethoscope for any bruits.
Bruits? What are those? Another type of murmur.
Similar, but bruits specifically refer to turbulent blood flow in the arteries. They sound like murmurs, but they originate in the blood vessels, not the heart itself.
And why is listening for bruits so important before we palpate?
It's all about safety.
Okay.
If there's a significant blockage or narrowing in the carotid artery due to plaque buildup palpating, the artery could potentially dislodge that plaque.
Oh, wow. That sounds dangerous.
It can be.
Okay.
Dislodging a plaque could lead to a stroke, so always auscultate first.
Okay, good to know. So how do we listen for a bruit?
We use the diaphragm of our stethoscope and place it gently near the upper end of the thyroid cartilage just below the angle of the jaw.
Okay.
That's where the common carotid artery splits into the external and internal branches.
Got it. And what are we listening for exactly?
Any whooshing or switching sounds that indicate turbulent blood flow. If we hear a bruit, it definitely warrants further investigation.
Right.
But keep in mind that bruits don't always mean there's a severe blockage.
Okay, so once we've ruled out any bruits, we can move on to feeling the carotid pulse.
Yeah.
Where exactly do we palpate?
We gently press just inside the medial border of the sternocleidomastoid muscle.
Sternocleidomastoid muscle.
That's the big muscle that runs along the side of your neck.
I remember that one from anatomy class. What information are we gathering from palpation?
We're assessing the amplitude, which tells us about the strength of the pulse. We also look at the contour, which describes how quickly the pulse rises and falls. And finally, we note the timing of the pulse in relation to the S1 and S2 heart sounds.
So just like with murmurs, each characteristic of the pulse can provide clues to different conditions.
Exactly. A weak pulse could suggest poor heart function or low blood volume. A bounding pulse might indicate a problem with the aortic valve. And a delayed upstroke could be a sign of a narrowed aortic valve. It's all about putting those pieces together to create a complete picture.
Wow, I never realized how much information we can glean from just feeling someone's pulse. It's incredible.
It really is, and that's the beauty of the physical exam.
Yeah.
It's a powerful tool when you know how to use it.
We've covered a lot of ground here, from the anatomy of the heart
We have.
to the nuances of heart sounds, murmurs, and those all-important pulses. It feels like we've been building a comprehensive toolkit for assessing the cardiovascular system.
Yeah, you're exactly right.
So let's take a step back and review.
Okay.
What are the core components of a thorough cardiac physical exam? What are those big picture things we're looking for?
First and foremost, we're observing the patient's general appearance.
Okay.
Do they seem anxious? Fatigued? Short of breath?
Right.
Are they pale or diaphoretic?
Okay.
These can all be subtle but important clues.
Right, because sometimes the patient's overall presentation can give us just as much information as the physical findings themselves.
Absolutely. And of course, we always start with those fundamental vital signs. Blood pressure and heart rate are our baseline.
Then we move on to assessing the jugular venous pressure.
Right.
Listening carefully over the carotid arteries for any bruits.
Uh-huh.
And then gently palpating the carotid pulse.
Precisely. And finally, we get to the heart itself.
Okay.
We're inspecting and palpating the chest, looking and feeling for any abnormalities.
Okay.
We're carefully locating the PMI, assessing its size and character.
And throughout this entire process, we're listening intently, right?
Absolutely. We start by listening at the base of the heart and work our way down to the apex.
Okay.
We're paying close attention to the intensity and any splitting of S1 and S2.
Uh-huh.
We're listening for any extra heart sounds like S3 or S4, which can indicate problems with ventricular filling.
Right.
And of course, we're carefully listening for any murmurs.
And if we do hear a murmur, it's not enough to just note its presence.
Right.
We have to characterize it fully.
Exactly.
How do we do that?
We describe its timing in relation to the cardiac cycle.
Okay.
Its shape. Is it crescendo, decrescendo, or does it have a different quality?
Right.
Its grade, how loud is it? Where is it best heard? Does it radiate to other areas? What's its pitch, high-pitched or low-pitched?
Okay.
And finally, we try to capture its overall quality. Is it harsh, rumbling, blowing, or musical?
It's detailed work, but it's so crucial for making an accurate diagnosis and developing a treatment plan.
It absolutely is. And to add another layer of complexity,
Okay.
we can use certain maneuvers to help us further characterize murmurs.
Maneuvers. What kind of maneuvers are we talking about?
Things like having the patient stand up, squat down, or perform the Valsalva maneuver. These maneuvers can change the dynamics of blood flow through the heart.
Right.
And that can change the characteristics of certain murmurs.
So it's like having a set of tools to really fine-tune our assessment.
Exactly. With practice, you become fluent in the language of the heart.
Yeah.
You learn to recognize the subtle variations in sounds and sensations, and those variations become clues that help you piece together the patient's story.
Wow, we've really done a deep dive here. It's amazing how much complexity exists in a single heartbeat.
It's truly remarkable, and understanding these fundamentals is essential not only for accurate diagnosis, but also for providing truly holistic care to your patients.
Because behind every heartbeat is a person, and their story is woven into those sounds and rhythms.
Beautifully said. As nurses, we have the privilege of listening to those stories, both with our stethoscopes and with our hearts.
So to all our listeners out there, whether you're a student just starting your journey, a seasoned faculty member, or simply someone with a deep curiosity about the heart, we hope this deep dive has sparked your passion for cardiology.
Remember, the journey of learning never ends. Keep exploring, keep asking questions, and most importantly, keep listening.
Because finding every subtle clue tells a story. And becoming fluent in that language is what makes a great nurse. Until next time, stay curious and keep those hearts beating strong.